I want to thank you all for joining this educational medical webinar provided by Handicraft Company's Medical Division. Today I am honored to present Mary Stanford. Mary has worked as a neonatal pediatric speech-language pathologist for over 15 years in the NICU, outpatient clinics, including craniofacial, cleft palate, and feeding clinics, as well as in state early intervention program settings. Mary has continued to pursue her doctorate in speech-language pathology at the Teachers College, Columbia University in New York City, and recently received her Master's of Philosophy at Columbia University Graduate School of Arts and Sciences. Mary has earned her Master's of Science in Speech-Language Pathology in 2000 from Columbia University Teachers College Graduate School of Education. Mary has worked with research teams at the University of North Carolina, Chapel Hill, and Virginia Commonwealth University to investigate preterm infant feeding behaviors and characterize in their feedings. Her research interests are focused on preterm infant oral feeding development, prevention of long-term oral aversion in the neonatal and infant period, standardization of infant-driven cue-based feeding assessment and interventions, and further investigation into the use and efficacy of the VF-SS as an objective assessment of swallow function in neonates. Mary has facilitated infant feeding practice changes within the NICU setting, engaged in program development for an outpatient feeding clinic to support the needs of infants with chronic feeding issues beyond NICU discharge. She has been a brand loyalist to Dr. Brown's products since the earliest days of her career when she began using Dr. Brown's products exclusively in the NICU. She currently works for Handicraft Company, makers of Dr. Brown's medical products, as an account manager, clinical liaison in the Eastern Territory. Today, Mary will be presenting the Neonatal Abstinence Syndrome Epidemic, Managing Infant Oral Feeding Challenges Through Individualized and Unit-Specific Interventions. Thank you so much for joining, and now I'd like to introduce Mary.
Thank you, Sandy, for that wonderful introduction. I'd like to take a moment to also thank Handicraft Company for continuing to support the educational needs of neonatal practice professionals across disciplines through these online educational webinars. It's an honor for me to present to this group today. Thank you very much for your time, and hopefully this will be a valuable experience for all. As Sandy mentioned, our discussion today focuses on the epidemic of neonatal abstinence syndrome that has affected almost every unit in the United States and abroad. Among states in the U.S., there are certainly states that are reporting higher birth rates of infants born to mothers with known or unknown substance exposure during pregnancy. As a result, we as neonatal care professionals are charged with developing optimal evidence-based care protocols, not only to provide the supportive care that's needed by the infants and patients that we treat, but also to develop protocols and guidelines, as well as the infrastructure support these practices within our units. As Sandy has already mentioned, I am employed by Dr. Brown's Medical Division of the Handicraft Company as a clinical specialist for the Eastern Territory of the United States. The objectives for today's lecture, we'll review 4 of those objectives. The first objective is to review the incidence and current evidence on the therapeutic management of neonatal abstinence syndrome. Secondly, we're going to identify the specific symptoms of NAS that impact an infant's oral feeding skill development and success during breastfeeding and bottle feeding. Thirdly, we're going to determine methods of constructing individualized infant and family-centered care plans that support the growth, neurodevelopment, and nutritional needs of an infant with NAS. And lastly, identify 3 effective interventions that individual neonatal intensive care units can develop to decrease length of stay and improved outcomes for infants with NAS. So this is a picture that I thought was important to start with, and this photo is titled The Unforgettable Cry. It was taken by a photographer and was posted on Worcester Magazine, who was covering a story on the NIS epidemic, which in 2011, Massachusetts had the second highest rate of infants born with NAS in the United States. And although not audible, this infant's face is truly unforgettable, but the cry of an infant with NAS is just that. It's unforgettable. It's characteristic. This cry has a completely different pitch, a different frequency. It has a different resonance than that of a cry of a typical newborn. And it is a hallmark of NAS, right? So a high-pitched cry is a hallmark of NAS. And we'll discuss some of the symptoms of NAS and how they can impact feeding later on in this discussion. But I thought it was important for us to start here because when we as neonatal practice professionals across discipline enter into the neonatal intensive care unit or into the newborn nursery and we hear this cry, it is a true call to action. We know that we need to assist in managing the symptoms of NAS for this infant and this family in order to support their short-term and their long-term outcomes. And we have to then put on a different hat than we're used to providing in the NICU specifically. It's a different type of caregiving, even though it has very similar pillars to our care. There are very similar pillars to our care. However, it's very different in how we're going to act and how we are going to speak, and just everything about our care will feel similar, but just a little bit different. And we need to be mindful of that. And we also really need to evaluate the evidence to support that practice, as we talked about. So today's lecture, hopefully we will take the puzzle pieces that we have in front of us. Since the landscape of NAS, we have some nice literature that's really starting to come out from some centers across the U.S., including Tennessee, Massachusetts, and Ohio, just to name a few. But we'll try to take that evidence and bring it together with maybe some of the myth that's out there, and hopefully we'll be able to, at the end, be able to speak to where we are in terms of our practice regarding NAS. So I think it's very important for us to start with the history of neonatal abstinence syndrome, and I thought this timeline was a nice way for us to just kind of look back retrospectively to see where this all began and sort of where we've ended up. And so the first point here that on the left-hand side of your screen is a red arrow pointing to 1875. And this was the first reported case of neonatal abstinence syndrome. Farther on down the line, you start this blue star that I've highlighted. And that is an indicator of a point at which we start to see methadone was developed in 1937, and in 1964, methadone maintenance treatment was established. At this particular point in time, there was also a period where there were some revelations in medicine regarding NAS, and so it's a big point at which we need to see how things evolved. As we go down the line, we can see that in 1984, 1989, and 1999, we have the opioid analgesic medications that were introduced: Vicodin, oxycodone, or Oxycontin, and Percocet. And one of the things I think that's big too, one of the big topics that I think that we need to unpack here is that the FDA approval for opioid dependence was approved in 2002, and then we see this incidence of NAS being reported a little bit more frequently later on. But just to revisit the 80s and 90s, we have the introduction of the opioid analgesic medications, and a lot of the research that was conducted back in the 80s and 90s really focused on more cocaine exposure in infants and things like this. But as we evolve into the 90s and obviously as we approach 2000, 2012, we start to see some different changes in the reported cases of neonatal abstinence syndrome. In 2002, the first reported case of NAS was due to Oxycontin, and of course, 2012, we now have an epidemic of neonatal abstinence syndrome in this country. And this is figure 1 from Koch Lakota's article in Pediatrics, August 2014. It's just a really important article. If you haven't had the opportunity to review it, I would highly suggest that you pull this article. It's also in my references. So as I've pointed out, NAS, neonatal abstinence syndrome, is a national epidemic. The Medicaid agency has declared NAS a national epidemic, and the Medicaid agency has been reported to pay for 80% of NAS cases nationally. So I would consider them to be the authority on whether or not this is an epidemic or not. The national rates of NAS have tripled since 2000, and so as I had mentioned earlier, some states with the highest incidence include Tennessee, Massachusetts, West Virginia, Pennsylvania, New York, Florida, Vermont, Ohio, Colorado, and Alaska. Another important point to really state at this particular point in the lecture is that no optimal management of NAS has been established. So we're challenged as caregivers to determine what really is the best strategies for patients in our care. Our care practice standards are inconsistent nationally, leaving individual units to establish the guidelines. And no known studies have compared the effectiveness of any of the interventional measures utilized with NAS, which is challenging again for us. As I mentioned earlier, in 2011, the Substance Abuse Mental Health Services Administration reported that 1.1% of pregnant women abused opioids, that 0.9% used opioid pain relievers, and 0.2% used heroin. And I think that that is an important statistic because it's not all illicit drug use. Actually, illicit drug use by these statistics are lower than opioid pain relievers. And although pain relievers can certainly be secured or gotten from other avenues, that pain relievers are often prescribed by physicians. So many of the patients that are coming to us with known or unknown exposure to substances, we have to remember that some of these women that are coming in with infants were prescribed these medications and they thought that they were following doctor's orders. So the way in which we view this medical condition when it arrives in our units, we really need to be careful and look through a different lens, which we'll talk about too. Maternal opioid use increased from 1.2 mothers per 1,000 live births to 5.6 mothers per 1,000 live births in 2009, and the diagnoses of NAS correspondingly increased from 1.2 to 3.4 per 1,000 live births, which is pretty dramatic. A study in Florida reported the number of neonates with NAS admitted to the NICU increased by tenfold from 2005 to 2011, and that's only 6 years. Increases in the incidence of NAS have been reported uniformly across community hospitals, teaching hospitals, and children's hospitals across the U.S. So this is not specific to any location in the United States or one socioeconomic bracket or one particular ethnicity or race or gender, color. So all communities and all ethnicities have been affected by this. And again, this is this information that has been provided through, looking through a lot of articles, but most specifically, I found that this article by Koch Lakota was just excellent in their evaluation of this epidemic. So here is a child who was recently admitted to the neonatal intensive care unit with a diagnosis of NAS, and as we know, NAS is a constellation of symptoms that make up the multi-system generalized disorder of neonatal abstinence syndrome. The effects of the drug withdrawal occurs as soon as the umbilical cord is cut, and those symptoms can be observed within 12 hours or up to 3 days, depending on the type of substance that the mother was taking, the frequency at which she was taking it, the amount at which she was taking, and also how the mother metabolizes those substances are really going to impact the baby. The symptoms of NAS that are observed in observational and behavioral assessments across systems include the autonomic, the central nervous system, and the gastrointestinal system. So we talked earlier about the high-pitched cry, although this is not a video and it's hard to show videos on webinars, but if you were to be standing above this baby's bassinet, you would see that obviously this baby is extremely irritable. He has his tone is a little abnormal for an infant who is what appears to be term age. Babies that are showing signs of NAS can also have jitteriness, tremors, convulsions, sweating, Infants are not known to sweat, so that's alarming to us. They sometimes can have elevated low-grade fevers, mottling of their skin, excessive sucking and rooting that usually is associated with poor feeding skills. We call that hyperphagia, and that's the basis of our lecture today. We're really just going to focus in on those feeding issues. Vomiting, of course, they are known to be babies who spit and regurgitate, and also have frequent and excessive loose, watery stool or diarrhea. So it's affecting these three major systems, but of course, as we know, when one system is affected, other systems can then also be affected. We've really gone through this. As I said, these three systems are the most affected by NAS, and as we do evaluations, we notice that some of the symptoms that infants are demonstrating are increasing or decreasing as a result of our care. So when we're looking at this particular figure, again, this is Kashla-Kota in 2014, Pediatrics, August 2014. This is the mechanism of opioid withdrawal in infants. And again, I thought this was a pretty important slide to show you, because if you look at the center of the diagram, you'll see this green circle. And what the green circle signifies is the infant and the lack of opioids in chronically stimulated receptors. And so you see as the opioids start to deplete after the baby is born, you see changes over time that are going to result in the behaviors that we're seeing. Again, these are the symptoms that we need to manage and the symptoms that we need to treat in infants with NAS. So it goes beyond really the drug. It goes back to the chemical responses that are occurring inside of this particular infant. And as we know, infants are all different. We're all individuals. So just taking a really hard look at this particular figure, I think, is important for us to understand what changes are happening and why they're happening. So non-pharmacological interventions, what we would refer to as supportive care, as neonatal practice professionals, this is really important for us, because this is, again, this is our call to action. This is where we can make the most impact for these infants and families. And the non-pharmacological intervention is the gold standard. It can be initiated before pharmacological intervention is started and should continue in conjunction with pharmacological interventions if that in fact does need to be initiated. So when we are providing supportive care, we want the elements of that are, of course, to decrease the environmental stimuli within the baby's space and area, providing minimal sensory and environmental stimulation. We want to maintain their temperature stability as best we can, provide cluster caregiving, which we'll talk about a little bit more later in our unit-specific protocol development. Encourage parents to engage in skin-to-skin, which supports improved outcomes, but something that we really should be considering from the beginning of this infant's admission. And again, we'll talk about that a little later. Encourage non-nutritive sucking for improved regulation. These infants are almost hyper-reflexive. They are wanting to suck, and there are ways in which we can really help to regulate them through providing opportunities, whether it be by pacifier or gloved finger, or again through skin to skin on mom's breast. Swaddling is very important for these infants because it provides that proprioceptive input that their sensory systems really need to get back their motor organization. So we want to maintain a firm, tight swaddle position, position the infant on the side or in supine to facilitate midline flexion. We want to bring their body into this nice sort of C-curved position so that they feel comfortable like they did when they were in mom's womb. Rocking has been shown to be effective in assisting the infant to self-regulate and to calm, although there's a lot of research that still needs to be conducted in terms of what the impact of vestibular input is, and of course that's rocking, has just by itself versus in combination with maybe some other intervention. So again, there's limited literature that's out there, but some of the literature that we have really we can start to dig into. Rocking is very helpful. And lastly, infant massage, of course, with a trained clinician, can be extremely comforting, calming to the infant and to the parent, and again, an opportunity for the infant and the parent to interact, parent and infant to interact. And when we're doing this, we need to be mindful, of course, when infants with NAS are rubbing or seeking inputs, they can be rubbing their skin against hard surfaces, blanketed surfaces, and they will have significant skin excoriation, especially on their elbows or their knees or face often. So we need to be careful of the skin products that we're using in the unit. So the assessment tools for evaluation of NAS in the opioid-exposed newborns, and as I said earlier, in many years ago, we had infants that were mostly exposed to alcohol, cocaine, tobacco, other substances, but now we're seeing opioids as being the prominent substance that we're having to manage in the unit. So some assessment tools that are used usually by nursing. These are not typical scales that are used by neonatal therapists. And from my understanding, the reason for that is that the nurses are the primary caregivers. They're at the bedside. They can provide these assessments, during care or after care, and also then can report this back to the medical team in terms of the results and whether an infant is in need of either pharmacological intervention or more of that intervention. So I think that's important for us to understand as therapists, that these are not interventions or evaluations that we conduct, but ones that we need to understand, because the results of those will certainly impact how we develop intervention strategies. So the first one is the evaluation of the opioid-exposed newborns. The second, and probably the most often used, especially here in the U.S., is the Finnegan Neonatal Abstinence Score System, or more often referred to as the modified Finnegan. Third is the Lipsis Neonatal Drug Inventory. That's recommended by the AAP, but it's considered too subjective in rating gross individual symptoms, so not as often used as the modified Finnegan. Thirdly, the Neonatal Withdrawal Inventory, and the fifth, Neonatal Narcotic Withdrawal Index. And these can all be found in Janssen 2009, who reviews many of these assessments. So here is a picture of an infant who obviously is being held by, we'll see this a little later, but a hugger in this infant's program. This is from the Tennessean. Again, it was a featured story in this particular journal publication that discussed the incidence of NAS in the state of Tennessee, and spoke to some of the interventions and programming that's going on in the state, as well as the incidence of NAS. So here we see an infant who the nurse is obviously providing oral medications. She's obviously, this baby has started not only a non-pharmacological intervention program, supportive care with a hugger, but also is receiving oral medications to start to wean them. So the pharmacological management occurs in 21 to 90% of infants with NAS. They receive, that's a pretty large number, but the average length of stay in infants that have been diagnosed with NAS is 18 to 25 days, and that's to provide the inpatient pharmacological interventions needed. Pharmacological management can prolong hospitalization and exposes infants to additional agents that are not often necessary. And I think here we also need to understand that when infants are staying for prolonged hospitalization, they're also not receiving the normal family experience and not getting the benefits of bonding with mom and family that they would get if they were not in the hospital. So it's very important that we really try to reduce the length of stay and get babies home as quickly as we can, safely, obviously. Opioids are currently considered the first line of therapy. Morphine is the most preferred medication due to the decrease in seizures. It improves feeding, eliminates loose stools, and decreases agitation. It controls the most severe symptoms. Methadone is the alternative to morphine. The second line of therapy is the non-opiate phenobarb phenobarbital. So phenobarbital is most often used in conjunction with methadone and morphine. It does not assist in eliminating the GI symptoms, and it's often used when there's evidence of polydrug use. Buprenorphine is a newer option of treatment administered sublingually and not studied largely to date. And lastly, the accurate and consistent scoring of symptoms and timing of medication delivery have an impact on treatment effectiveness. So that's why we're going to talk about later when we review unit-specific protocols, why being able to accurately assess the symptoms of NAS is very critical. So one particular study that I thought I would bring up, since we have discussed earlier that there are not many studies that demonstrate the effectiveness of treatment, and that there's no optimal treatment that's been established. So one particular study by Hall 2014 was a multi-center cohort study of treatments and hospital outcomes in infants with NAS, and it compared the pharmacological treatment strategies for NAS with respect to the total duration of opioid treatment and length of hospitalization. So 20 hospitals in 6 Ohio regions, and the study was conducted between January 2012 and July 2013. It included 547 late and preterm infants that were treated with inpatient pharmacological treatment for NAS. 417 infants were managed using an established weaning protocol, and 130 infants were managed without a protocol. The protocol that they used was decided upon. They looked at 6 of those, six regionally based weaning protocol strategies that had been used, and they established 1 out of the 6. So that's what the 417 infants were managed using that one specific protocol. The results indicated that regardless of the opioid treatment offered, patients in the protocol-based weaning cohort had significantly shorter periods of opioid therapy at 17.7 days versus 32.1 days, and shorter length of stay of 22.7 days versus 32.1 days than those infants without an established protocol. So that's a huge difference, and so that's very powerful. No difference in duration of therapy or length of stay when compared to morphine therapy versus methadone therapy. And I think when we talk about that slide earlier between myth and truth, I think that there's some discussion out there that one is better than the other. But again, in this study, and this is just one study, it says there's no difference in duration of therapy. And lastly, the patients receiving phenobarbital therapy had a longer duration of therapy, which I thought was interesting because, oftentimes, at least in my clinical experience, I've seen phenobarbital used most often, most frequently. So now that we've come to this part in the talk, this is kind of the part we've been waiting for, right? So we're going to start to talk about how we're going to manage oral feeding challenges for infants with NAS. And again, we talked about the incidence of NAS in the U.S. and how it's managed, but really, again, we're going to come back to if we're managing oral feeding challenges for infants with NAS, we're really pulling more from not only the pharmacological benefits that the infant is receiving if they're getting pharmacological treatments, but also we're really going to be impactful here with our non-pharmacological supportive care as we start to look at the feeding behaviors that infants with NAS have. And I think just to give a little background, I, as a feeding clinician, as a feeding specialist, have often been brought in on cases when an infant is just not being able to feed. Typically, they're really challenged, whether it's because of GI distress or because of their just significant incoordination, where nurses are just kind of pulling in to say, can you give me a little bit more of a perspective on what do you think is going on with these babies? So I think it's important for us to really look at the qualities of the oral feeding skill observed in infants with NAS, because again, they can have some similarities that look as if they have immature features, that they're more like a preterm infant or late preterm infant, but then there are these very different behaviors that they show that definitely speak to the fact that they are not preterm or late preterm in certain cases. So The qualities that we observe typically are the incoordination of suck, swallow, breathe patterns, the sensory integration challenges that they have, again with that hyper-reflexive suck and rooting response. They have a maladaptive tongue positioning when attempting to place their bottle nipple or their breast intraorally. So you'll see them do a lot of tongue thrusting, placing the tongue on the side or above the nipple. And again, that's that frenetic kind of disorganized motor behavior that we see more in a sensory, see more of a sensory response. They have difficulty maintaining motor control during feeding due to hypertonia. They have an inefficient suck with poor intraoral seal, inefficient bolus expression, so you'll see them sucking at short bursts with a relatively weak suck, and then excessive and strong sucks during non-nutritive sucking on a pacifier gloved finger, which is just so confusing most often to the caregivers, right? They just really can't put their head around why, or their hands around why he looks like he's real eager, she's real eager to eat, and she has a really strong suck when she sucks her finger at my breast or on Passy, but when I put the nipple in her mouth, everything just kind of goes out the door, like literally. So fluid loss at the mouth corners, and that's what I'm talking about. So everything starts getting lost. As the baby attempts to feed, you see fluid leaking out the corners, the clicking during sucking, which indicates that the tongue is slipping off the back of the nipple, with gulping, again due to that discoordination. Infants will either self-impose a break to pause for breathing, or we as caregivers have to provide that for them because they won't stop and we don't want them to get into trouble. And that I mean them basically sucking and not breathing to the point where they become apneic. They will frequently have loud burps due to the ingestion of air, significant gassiness. They are often known to spit up, regurgitate, vomit post-feeding or even during feeding, and also have loose, watery stools, which can have a real impact because if the baby's bum is excoriated, which many babies with NAS have, if they're feeding and you've got them in a place where they're sort of regulated and they're getting organized, and then they are to have a stool or movement at that time, the acid in the bowel movement actually burns their skin. That can cause them to just completely unravel again, and you've got to start back at square one. So the effects of not only the effects of the substance that they were exposed from, the effects of them weaning, and then the effects of the symptoms they're experiencing all kind of come into this perfect storm, which cause them to look as if they don't know how to eat. So, this is a really challenging part of the lecture because we look at the evidence, we look at the evidence-based assessments for infant oral feeding skill and behavior, and although one of them in this on this slide is not a feeding assessment, you're really challenged as a clinician to figure out how do you identify or characterize these qualities of feeding so that you can provide a framework for the medical team and provide a framework for yourself to develop an intervention strategy to really support these babies so that they're feeding well and they're feeding successfully and positively, and helping parents to gain that confidence that they can feed their infants. So the first assessment that I'm just going to speak to is the NICU Network Neurobehavioral Scale, and that's by Lester and Tronick in 2004, and that was out of Brown. And this is an assessment tool that does not look at feeding behavior necessarily, but it looks at the withdrawal symptoms that an infant can demonstrate, and it looks at all these different areas of the infant's development and responses to the environment. It does assess non-nutritive suck, and from a neonatal therapist perspective, I think it's an extremely important tool for us to be looking at even before we start to look at nutritive feeding behaviors. So really the only three feeding assessments, evidence-based feeding assessments that I thought we should review today are the Early Feeding Skills Assessment by Dr. Sue Thorey, Catherine Shaker, and Karen Pridham in 2003, the SOFI method, which is supporting oral feeding in the fragile infant by Dr. Aaron Ross and Kathy Philbin in 2011, and of course the Neonatal Oral Motor Assessment Scale by Marjorie Mayer Palmer, which was developed in 1983. So these are the three major feeding assessments that are currently utilized by a neonatal therapist, with the exception of maybe one or two that I didn't include, but they're more specific to preterm infants. But again, I thought it was important to review the NICU Network Behavioral Scale because it was designed to provide a comprehensive assessment of neurological integrity and behavioral function. It examines the neurobehavioral organization, the neurological reflexes, motor development, and active and passive tone, as well as signs of stress and withdrawal of the at-risk and the drug-exposed infant. So maybe even you can use this before you understand that an infant or come to know that an infant has been exposed to substances during pregnancy. Again, as I said earlier, the non-nutritive suck is assessed. It's scored with a gloved finger placed intraorally, and there are 9 possible scores in this section. Nutritive sucking is not assessed. It has required training and certification to administer. The SOFI method, I believe in looking at all 3 of these feeding assessments, is the most ideal for assessing an infant with neonatal abstinence syndrome. And the reason for that is that it is it's evidence-based with healthy preterm and medically compromised term and healthy term infants. So you have you have the ability to assess the infant who is demonstrating symptoms of NAS against against norms that are of healthy term infants. And it is cue-based. It focuses on the stability and quality of the infant's feeding experience, which is extremely important with infants with NAS. And it incorporates the guidance to improve stability, support skill development, and attends to the environment. And bullet number 3, I don't think could be emphasized anymore because this is really the basis of an intervention in the NICU or the newborn nursery for feeding success. Right here, you have to incorporate guidance to the caregiver and to the infant to improve their stability and support their skill development. Because even though the baby in some cases is healthy, late preterm or term infant, their skill development is still evolving. So we have to continue to support and keep them on track for normal development or typical development. And attends to the environment, which is something that can really affect infants with NAS. They're very sensitive to their sensory systems are very sensitive. Secondly, the early feeding skills assessment by Dr. Thorey, Kathy Shaker, and Karen Pridham in 2004. It's a checklist for assessing infant readiness for tolerance of feeding and for profiling an infant's developmental stage regarding specific feeding skill, the ability to maintain engagement in feeding, organize their oral functioning, coordinate their swallowing and breathing, and maintain physiological stability. Now, this could be called into question if you were to use it because this is most often used with babies who are preterm, late preterm, and even just term, and what is not, it's not evidence-based, was not created for babies with NAS. So, often, someone might say, well, why would you use the EFS? Because if anything, a baby with NAS doesn't show, the infant's always showing signs of readiness to feed. They're hyperactive, they are hyper alert, they are, hyper reflexive. They have hyperphagia. So why would we assess that? That's only one part of the assessment tool. So yes, they're showing readiness, but are they showing signs that they want to feed, or are they showing signs that they are irritable and they are not able to regulate? There are differences. So when we look at cues, we need to be careful about what cues we're seeing. Are we seeing cues of regulation and of calm and soothing? Are we seeing cues of distress and need for support? So that's why I thought the EFS would be a tool that could be very helpful. It's used on babies that are bottle and breastfed. It could be administered to infants who are preterm up to 3 months post-term, which is important for babies who are weaning. It does require training, and clinical staff does administer this evaluation, but I've used this tool for many years, and this is a tool that you can relay very easily to parents. It's user-friendly on both sides, both clinical and for parents, and so parents can really start to embrace the language that you're using, and they can start to communicate more effectively with the team, and that's one of our main objectives when we're trying to empower the caregiver to be the primary caregiver once they go home. And also it provides a glimpse into the infant's strengths and weaknesses. So it assists in developing the individualized intervention plan, which is, again, where we're going with this, because every baby is different depending on the substance they were exposed to, the family environment they're going home with, and of course the skill that they have. So I think it does help frame up a nice individualized plan. Lastly, we're going to talk about the Neonatal Oral Motor Assessment Scale by Palmer, and Although I thought it was important to bring this up because it is assessment of tongue and jaw movements during non-nutritive suck and nutritive suck. It's scored at the onset of oral feeding for the first 2 minutes, so the duration of 2 minutes at the beginning of the feeding. It categorizes tongue and jaw movements into normal, disorganized, and dysfunctional, and provides insight into the oral motor functioning during PO feeding. It can be used with infants that are either being breast or bottle fed, and it does require certification and training to administer, which is often a challenge because not if the clinician is certified, maybe the people in the unit are not wholly certified and trained to administer, so there may be a communication breakdown on really what the diagnosis is. And it does not assess other areas of neurodevelopment, neuromaturation, tolerance to feeding, or other associated behaviors, and especially the environment. So of the three, this would be the feeding assessment that I may use in conjunction with the SOFI or the EFS, in addition to maybe the ENDS, which we talked about earlier. So the reason I brought all of these together is that I don't think that one can serve all purposes. I think that we look at what we're looking to assess, and we sort of look at the whole baby and decide what what assessment is going to give us the best picture of this baby. And so I think that using a variety of these in combination can really help us to get that clear picture, right? And that's what we need to have, very clear picture. So we're going to move to breastfeeding, which is the first line of nutrition for babies. And this, I think, we're moving from myth to truth here. So the American Academy of Pediatrics removed the restriction on breastfeeding for mothers of methadone in 2011 and reaffirmed that statement in 2013. That's very, very important because many years ago, when I first started working in the NICU, we always were instructed not to encourage moms of infants with drug exposure that they should breastfeed, which I always thought was so strange, but I was glad to see the statement by the AAP. Breastfeeding, as we know, it supports overall growth, it provides optimal nutrition, promotes maternal-infant bonding, so critical to infants of NAS and that mother-infant dyad. It decreases maternal stress due to infants' NAS symptoms and hospitalization, which are very ramped up in mothers of infants with NAS. Assists with promoting infant sleep patterns, which they definitely can use help with. And it's the most useful when you can collaborate your team, right? You can collaborate and bring in the lactation specialist to assist with the infant's extraneous movements, their latching, their irritability during feeding. The same types of behavior qualities that you're going to see during bottle feeding are going to be very similar to breastfeeding, but with breastfeeding, we have actually mom to help to regulate. We have skin to skin occurring. We can position the babies in different ways that can really help them. So we have to look at the calming, the conditioning, and the positioning during breastfeeding to really establish great feeding. Multiple studies have validated that breast milk contains only minimal quantities of methadone and buprenorphine, and the amount is too small to treat NAS as a standalone treatment. And let me just say that here, it doesn't mean that it's not effective in assisting with the management of breastfeeding. It means it just can't be the only measure that's used. So just to clarify that point. Discontinuing breast milk is not associated with a worsening of NAS, and again, this is a myth that I think often we hear that maybe mom ran out of milk, mom doesn't have enough, hasn't been producing, whatever the case may be. Breast milk is no longer able to be provided, and now the infant seems to be worse. I think looking deeper into that was the mom actually breastfeeding and now no longer is producing, and the interaction and the skin to skin that the baby was receiving more frequently is no longer occurring. Maybe the heightened or the what we call the worsening of NAS or the heightened symptoms that we're seeing, but I think that we need to evaluate that because it's not correct, right? Discontinuing breast milk is not associated with worsening of NAS, so please know that if that's a myth going around. So we also should look then to several research studies that have shown that infants with NAS who are breastfed or fed breast milk had lower Finnegan scores and fewer babies required pharmacological therapy, which is great. Breastfeeding the infant or feeding the infant breast milk may allow for more aggressive weaning from methadone, resulting in earlier discharge and a shorter length of stay in the hospital, which is ideal. Breastfeeding is not contraindicated with psychotropic medications. The only time breastfeeding is contraindicated is if a mother is taking illicit drugs, has polydrug use, or is infected with HIV. Hall in 2006, which is this article, Clinical Management of Breastfeeding of the Breastfeeding Mother, Infant Dyad in Recovery from Opioid Dependency in the Journal of Addiction Nursing, June 2016. I thought these three statements were very important for us to just think about and take with us each day. So it is our moral and ethical responsibility as healthcare professionals to enable, foster, and promote breastfeeding among all families, especially those who stand to benefit the greatest. Substance recovery cannot be treated in isolation, nor can breastfeeding efforts. An interdisciplinary professional team effort promises the greatest chances for recovery success. With appropriate evidence-based practice support, training, and intervention by knowledgeable professionals, many women can overcome the biases and obstacles associated with opioid recovery to successfully breastfeed their infants. I think this is also true for babies who are bottle fed, but I think that it's just important for us to understand that one person can make a difference in a family. So because maybe we don't have, the protocols and the infrastructure set up in our units just yet, being able to put your hands around an infant and a mother who are in your unit, you can impact them in the long term. You can make a difference. So changing your lens can really be powerful. So we're going to get into a suggested oral feeding protocol, suggested oral feeding intervention protocol. And there are three main elements to this suggested oral feeding protocol. And this is one that has really just been developed over the years of managing infants and families with NAS. And the three main elements are that we need to understand the environment, we need to be able to organize the infant's state, motor control, and attention, and then also we need to understand what type of bottle and nipple type we're using. If that is breastfeeding, of course that would fit in there too, but for this specific protocol, we're going to talk about bottle feeding. So, but please feel free to, if you were to use an example like this, you can present breastfeeding into this area of bottle or nipple type. So first, in the environment, we're going to assess the infant's feeding environment and make adjustments before feeding begins. And that means that we need to assess the bed space. In some units now are actually changing the entire area around the infant. They're actually creating units that have very low stimulation, that are calm, quiet, low lit, and they're eliminating the distractions. So environment is very, very important. And there's a unit in East Tennessee, Carla Saunders. Dr. Carla Saunders is a neonatologist out there, and she's done an excellent job. And her and her clinical team have developed a unit specific for babies with NAS. So this is very important for us to look at. If you're looking at your environment, you're looking at the infant's environment, and you're realizing that changes need to be made, going around and trying to figure out how those simple changes can be made without, of course, changing the infrastructure of your facility or the unit itself. Okay, so secondly, we're going to look at the organization of state, motor control, and attention. So there are a couple elements here. We're going to assist the infant in maintaining a calm, alert state for feeding. We're going to support their transitions from a sleep to awake state. If awakening to feed, we don't want them to come out of a sleep state to that hyperactive, excessive crying. We want them to transition slowly to that wake state, wake up and start to help them self-soothe and self-regulate. Through that, we would offer them a pacifier or gloved finger to organize state, oral, and motor functioning and breathing. We would, of course, then swaddle them tightly in midline flexion so their knees are up, their elbows are bent, and their hands are towards their face, just making sure that they're in that nice, of course, encouraging midline flexion. After we have the baby swaddled and the baby is now sucking non-nutritively on a pacifier or gloved finger, we're going to transfer that infant with a slow transition from the crib side to the feeding location. And that could mean from the bassinet or the isolette, from a high point, right, above a seated position. From that high point down into mom's lap or down into caregiver's lap. And so assisting with that transfer, whether it's mom transferring, whether it's mom or caregiver transferring, or we assisting them, being very conscious of how the infant is impacted by that movement. And again, we don't have a lot of evidence right now to speak to how that vestibular input is impacting them, but of course we know as neonatal caregivers that we need to watch the infant's tolerance for any type of change in not only their environment but their motion. And vestibular input can calm an infant, but it can also be excessive, and they can have a poor response to that as well. So lastly, the position of the infant in an elevated sideline position on a pillow or cradle in a caregiver's arms is very important, and one that I think sideline positioning often gets called into question, especially when we're feeding babies that are preterm to late preterm and then term infants. The question is often, well, when do I stop sideline, or why is it necessary? And for preterm infants, where we're working towards gravity to bring the jaw and the tongue down forward and try to get some different types of tongue and jaw movements during sucking, that's a different rationale. But for infants who are especially late preterm and term infants who have these excessive movements and this high tone, when we swaddle them, when we get them nice and in that nice midline flexion, if we put them on the side, we break their tone. So we don't allow them to really increase tone by leg bracing or pushing their arms and legs up off of a hard surface. And so we encourage a more controlled movement and calmness. And so whether it's them lying in your arm or using something like the Dr. Brown's Gia nursing pillow is an excellent tool. And not just saying that because I work for Dr. Brown's, but it really is. I think it's one of the best breastfeeding and supportive positioning tools that you can use for babies that are bottle fed. It's not hard, it's not high, and so infants can really sink into it and not push up off of it and increase tone. So definitely something to look into if you haven't already. Then the last category we're going to look at is selecting the bottle type and the nipple type. So when we're offering babies, now we have the baby in the best position and the best, we set up the stage so the baby can have a successful feeding, hopefully. And so now what tool are we going to use? So we're going to offer the oral feedings through a slow flow nipple due to the infant's hyperactive sucking reflex, that hyperphagia that we were looking at, or talking about earlier, sorry. And there are differences in milk flow rates among slow flow nipples. And so I'll show it briefly, but I'm not going to discuss this specific study today, but Britt Pados' article published in 2015 in AJ-SLP, she tested the milk flow rates and variability in flow of the currently available nipples for infants who are hospitalized. And 9 of those nipples were slow flow. And there are differences between them. And the reason we need to understand that is that not all nipples are the same, but that they provide the infant with consistency, and there's a reliability in that flow rate that is important for us to understand, because when you have consistency and reliability, you can then measure the infant against the tool versus having to evaluate the tool as it being an issue in the infant's feeding challenge. So, we'll look at that in a second, but number one, consistency and reliability, but I'm going to go back to why slow flow. If we have a baby who is hyperactively sucking, who looks as if they want to suck, why would I slow them down? And the reason you want to slow them down is, remember, we looked at the qualities of feeding, oral feeding behaviors, and when an infant has poor regulation, right, and they are unable to coordinate, suck, swallow, breathe, what we don't want to do is give them a very large bolus to be able to manage, because that's where you're going to get the gulping, that's where you're going to get even more disorganization. So if you can help them to control not only bolus size but bolus transit, you're going to see a lot more efficiency in their feeding and more successful feeding, and probably a lot less of these other symptoms of poor feeding that we're seeing. When you're looking at slow flow nipples, I'm going to show you Britt Pados' article here in a chart in her article in a second. And one thing to again look to is the differences between some of the brands of slow flow nipples that are out there. Again, I'm biased towards the Dr. Brown's, but the ultra premium, the premium level silicone standard nipples used with the natural flow bottle it's excellent for managing infants with NAS because they have symptoms of GI distress, which the natural flow bottle assists them with, and coupled with the consistency and reliability of the standard silicone nipple, it's just an excellent tool to support them from an overall standpoint. So depending on what tool you use, you're going to offer pacing to assist the infant to coordinate sexual breathe patterns due to the increased work of breathing they have, if that's evidenced. And again, that assists with bolus management if the flow rate is still too fast. Feeding should not be extended beyond 30 minutes. And I know this is a big problem with a lot of this is a reported issue from a lot of practice professionals that are managing infants with NAS in the unit, that it takes forever to feed because the baby's stopping and starting, the baby's so disorganized, the baby vomited, there's just so much disruption during the feeding. But if we start this infant off on the right foot and create a good environment that helps to organize their state, their motor control and attention, and select the right bottle type, I think that we can limit these feedings to 30 minutes, which is appropriate. And again, we want to be as typical in how we provide care, and also understanding that it's a special type of caregiving, but remembering that we're trying to put them back on the tracks here. When burping, instead of sitting a baby up very, very quickly and starting to pat them, which is just it's what we know to be typical. We want to do this with a more slow transition to an upright position, rubbing the baby on the back from the hips all the way to the shoulder, and just rubbing in nice circular motions. We want to wrap and start patting the baby, because then we take away all the baby support that we just gave them. So we were taking away their trunk control, we're taking away their rib cage support. We then are offering input by banging on their back, by patting on their back. We're giving the sympathetic system, lots of input to work with, and so now we are really encouraging dysregulation by doing this. So even though the baby's not preterm and not particularly fragile, as some very low birth weight infants who start PO feeding at 33, 35 weeks, they're very small and they just seem more fragile, we tend to treat them a little bit more gingerly. So we need to treat babies with NAS just the same. Okay. So now this is Britt Patos's, this is a figure. This is actually figure 4, I apologize. And this is not the milk flow rates of all the nipples tested, but it's the coefficient variation of milk flow for all the nipples. And the reason for this one is that of this in these figures, it lists all of the nipples that I wanted to highlight here, and so the blue arrows indicate the slow flow nipples that were tested. And I encourage you to go and read this article, because it's just very insightful. It gives us the first real evidence on milk flow rates and the differences between the commercial brands that are used out there currently. And as Britt Patos is quoted as saying in this article, milk flow rate can be an easily manipulated variable that may contribute to the degree of physiological instability experienced by infants who are medically fragile during feedings. And again, I just said that infants with NAS are not considered medically fragile, as some babies that are with significant BPD or CLD or cardiac issues or combination of that, but they are fragile. Their sensory and their motor systems are fragile. We can upset the homeostasis that we're attempting to establish with them. We can upset that by not understanding their needs, and their needs are very similar to that of a late preterm or preterm infant when it comes to feeding. Bottle feeding and nutrition, there's a little bit of a difference here with how we provide nutrition to infants with NAS. Infants with NAS have a higher caloric requirement due to the energy expenditure associated with increased crying and activity, decreased sleep, and calories lost to the frequent spit up, regurgitation, vomiting, and diarrhea that they're experiencing. Their caloric needs are often reported to be as high as 150 to 250 kcals per day, which is pretty high. Feeding with a hypercaloric formula, about 24 calories per ounce, may be required to meet their nutritional needs and facilitate weight gain. And we might need to provide frequent small feedings every 3 to 4 hours to minimize hunger, allowing for adequate growth and decreased symptoms of distress. And I think this is important to understand, because when you are offering higher calorie formula into a GI system that's already having symptoms of distress as a result of weaning from medication, okay, and the neurology of the gut is a little bit unwound at that particular point. That's why we're seeing such GI unrest. Because babies are hyperphagic and they're looking as if they want more and more and more volume, oftentimes they're overfed by clinicians, clinical practice professionals, because we think that we are providing them with what they want. But remember, they are not typically showing behavior. They're not showing typical behaviors that healthy infants show us. So even though they may look as if they want more food, we need to be very careful that when we are providing a hypercaloric formula, increased calories will also decrease the rate at which the gut empties in a typical infant. So if we're putting more volume with higher calories, we have to realize that we may be causing some slowing down of that digestive process, and that may also be causing some of the spit up and regurgitation and GI distress. So we need to be careful and balance them equally. Establishing individual therapeutic goals, infants' symptoms and feeding challenges. We're going to consider the infant's symptoms of NAS given the substance they were exposed to. We talked about that earlier. So what is this particular infant that you're assessing and providing an intervention to? What are they experiencing? We want to create a healing environment at the bed space that allows the staff and family and the caregivers to provide effective care to the infant. So low stimulation, low lighting, and maintaining low noise levels. Neurobehavioral assessments need to be conducted. We talked about the ends earlier. This can help to capture the withdrawal symptoms and develop the individualized interventions. And then, of course, an oral feeding assessment. So evaluate the infant's oral feeding skill during breastfeeding and bottle feeding, and using the standardized scale or assessment tools or tool. And we've provided some of those for you today. The oral feeding goals that I really like to make sure to encourage breastfeeding always if possible. Select a feeding solution that supports the individual infant's feeding skill and family goals. So ask the questions. What is it that you would like to see during your infant's feeding? How do you want these feedings to go? And do you understand why this particular bottle system, for example, the Dr. Brown's, why do you need a Dr. Brown's bottle? And why is it beneficial for you and for the baby, and talking about how the internal vent system can support the infant's GI functioning and alleviate some of the symptoms of GI distress that the baby is experiencing, as well as the benefits of the consistency and reliability of the nipple, for example. Obviously taking a multidisciplinary approach to intervention, we collaborate with all disciplines involved with feeding. The lactation specialists, feeding specialists, nutritionists, nurses, nurse practitioners, physicians, and of course case management all need to be involved in feeding, believe it or not, and develop an individualized feeding plan. So continue to evaluate the behavioral and feeding skill challenges that the infant presents during weaning and as the infant matures, and make changes to the plan as needed. So once we do an individualized feeding plan, we have to come back every 2 to 3 days as infants change, and continue to update the family on why we're changing it or why we're not changing it, and keep them involved in developing those individualized feeding plans. Provide one-on-one training from the parent from the onset of the feeding. So often, in units that I've worked in before, we'll have the mothers and the families involved in the feedings at the start, so that they are guided through our instruction and through their participation, and they can start to see the variability in infants' behavior. And we can teach them how to manage the infant, watching for cues and changes in behavior and skill, and what possible changes can be made to assist the infant and the mother to continue on, beyond discharge, successfully feeding. And so the ultimate goal here is to empower the parent to be the caregiver, because when we're not there anymore, they'll need to problem solve, and we need to teach them how to problem solve. And let's not assume that they know how to do that. Oftentimes, moms, whether their babies are in the unit because of a diagnosis of NAS or they're in the unit because their baby ended up in the NICU, they oftentimes are first-time moms, and they have been ripped from just the ability to get typical information from their friends and family, the way that a lot of cultures have done for many years and passed down these traditions. They don't get any of that. We are teaching them, and so we need to be really intentional and present when we're doing that. And lastly, set the stage for feeding success during hospitalization and beyond. You want to teach them how they feed their infant at home, not just in the hospital. And so we don't want them feeding their babies in this very regimented way. We want them to be able to work with the baby during the feeding and kind of be able to make shifts in the plans that we set for them, not being rigid, right? So of course, an individualized feeding plan doesn't necessarily work unless you have a framework in which it functions within. So you have to have established unit-specific standards for providing care to infants and families in the units that are coming in with NAS, just like we do for babies who are born premature. So, of course, that would entail a multidisciplinary approach that includes parental participation, which we talked about, encourage the parents' presence and participation from the infant's admission. They're dealing with shame and guilt, embarrassment, anger, sadness, depression, all types of emotions, and teams that can work together to provide a safe, welcoming zone for families have reported that they see much more success. Engage in active listening, provide methods of open communication, be non-judgmental, respectful, and lead with empathy. Support the infant and the family bond, interaction, and attachment as quickly as possible from admission. The third thing is to think about how parent-caregiver meetings are held. So, with families with infants admitted to the NICU due to NAS, we tended to have more frequent meetings with them that were shorter in duration, provided multi-modality education materials, including handouts, web-based education, tablets, and support meetings, kind of giving them a well-rounded experience in terms of education, training, and support, because any parent in the NICU doesn't have the bandwidth to be able to retain large amounts of unfamiliar information, and there's studies on that too. So, being fair to the parents in terms of how they get this information, how it's related to them. Develop a care team of clinical champions for NAS that meet regularly to discuss current practice changes, review the evidence to support the practice as it comes out, because as the landscape is a little it's not so hardy at the moment. It is coming. There are more studies that are currently in progress. Evaluate the effectiveness of interventions provided and review follow-up data from your own particular unit, because that will give you a measure as to whether or not the interventions that you're using are impactful. Provide staff education, training, and services and regarding the rationale and methods for care delivery of non-pharmacological interventions. And I think it's important here to include the non-clinical staff in education. The departments like housekeeping, pharmacy, lactation, bioengineering that maintain the equipment in the unit. They are bioengineering, for example, they can assist you in creating a calm, quiet environment with decreased noise, maybe changing the lighting, helping you with the actual equipment that's in the unit, providing them with some insight into what you need. Provide education to the volunteers regarding the rationale and method for offering specific interventions. For example, why you are rocking and swaddling a baby versus moving them up and down vertically, or unwrapping them, or doing some other things, and why infants have specific feeding plans when they're weaning. And just providing them with more rationale so they can be supportive of those plans. Training and maintaining non-judgmental staff. Caring for the caregivers. There is a high incidence of burnout amongst caregivers who manage infants with NAS. They need a break. They need to be provided with the support, and the struggle that they're feeling is real. So it's a lot. Again, it's a different type of caregiving. It's more time intensive. It takes a lot more. It takes just a lot more of our empathy and our patience and understanding. And these babies are struggling to maintain, again, homeostasis, and so we really need to put all of our energies toward them. Maintaining language when we're discussing care plans in the unit and during meetings, so we're not referring to these babies as the NAS baby or the drug mom or the drug baby. That's not going to help the the lens at which you're looking through is going to become very clouded and not what we want to project in terms of a positive, empathetic way of caregiving. We need our caregiving to be consistent, so our scoring, reporting, documenting, communication, timing of delivery, and having defaults in place when those things don't happen. And of course, if you have the opportunity to either develop or utilize a cuddler or hugger program, this is really great because they're an extra set of hands that, of course, we know when we're managing babies with NAS, we could definitely use. This is a picture of a volunteer who is, just basically holding this baby and trying to calm him and help him to transition from a wake state to a sleep state, and hopefully have better sleep, which impacts their growth and development. And so these are really nice adds to our interventions if we have them available to us as resources. Again, interventions to support positive outcomes. It goes without saying, skin to skin. Can't say it enough. Breastfeeding and offering breast milk whenever possible, and implementing. I think the biggest take home here is to develop a standard process for identifying NAS, evaluation of NAS, treatment delivery, and discharge of an infant with NAS that includes an individualized and family-centered intervention. If your hospital or you have the opportunity to evaluate single rooms where families can stay in, room in with the infant, this is starting to show better. We're starting to see better outcomes and to stay when this is possible, and create a culture of compassion, empathy, and healing for the mother-infant dyad with NAS. So these are some quotes from a mother with NAS, and I thought they're, again, pretty important to share with you. So this mother said afterwards, "I still feel ashamed that I put him through that. The big thing about addicts that nobody gets is your guilt never goes away. And the women that are going through this have no allies. And thirdly, no one thinks they deserve their kids. The thing people need to know is nobody wants to be like this." I think that that's important to understand. And I think that we all, at one point in our experience with managing infants with NAS, maybe we thought that, mom didn't care, and so she just, she cared more about herself than she cared about her baby. And it's not our place to judge. First of all, it's our place to care for the infant and the family. So, we have to kind of drive through that myth and straight with fact, and know that if we can provide this type of positive, welcoming, empathetic, compassionate caregiving in that type of environment, we can really impact outcome. And that's evident here in this picture with this mom and this beautiful little baby boy, and they're looking at each other and obviously having some nice time together, and this, babies learn from. Outcomes for infants with NAS, we have seen altered maturation of neuronal connective tracts and smaller neuroanatomic volumes in infants born to opioid-addicted mothers, and that's established the urgent need for studies of long-term outcomes. There's no significant adverse long-term outcome where neonates who were reported to be exposed in utero to SSRIs, SNRIs, TCAs, and benzodiazepines or methamphetamines. So that's good. I hope that continues. Infants with NAS are more at risk for developmental or short-term and long-term neurodevelopmental challenges such as failure to thrive, behavioral, educational, and developmental issues. And that's concerning, and something we also need to understand when we're developing our interventions in the NICU, that often infants that are exposed to substances in utero are often born premature with IUGR and are low birth weight. So they are at a very high risk of developing future developmental challenges. Few studies on long-term developmental outcomes in infants with NAS have been performed, and so therefore more research studies are needed to evaluate the impact of specific interventions and treatment strategies on the long-term outcomes. And this is a little girl who spent some time in the NICU and weaned successfully, and is now being evaluated by her follow-up team, her developmental follow-up team, and doing very, very well. And this is the result that we want to end with, is that our caregiving can be impactful and support positive outcomes, and developing these individualized care plans to support individual families and infants and those within our own walls can be hugely successful. So thank you very much for your time today, and I'll take any questions if you have them.
Thank you, Mary, for that very informational webinar. We really appreciate your time and all the information that you shared with us. It was impactful. I do have a couple of questions. The first question I have is, if breastfeeding doesn't decrease NAS, why are breastfed babies' length of stay shorter and they have less symptoms?
Well, that's a good question. So in my presentation, I stated that breastfeeding is the first line of nutrition and is the optimal feeding modality, if possible. In fact, there are several retrospective studies that have examined the effect of breastfeeding on NAS. And so there are two studies that I can refer to specifically of infants that found that infants with NAS that found that the hospital stay of those who are breastfed during NAS therapy, their length of stay was 5 to 6 days shorter than the stay of those infants who are not breastfed. And then there's another study that the duration of NAS therapy was reduced during breastfeeding in infants when compared to non-breastfed infants. And a fourth, there was a finding that breastfeeding reduced the infants requiring treatment for NAS. And lastly, there's a small study that found that the need for NAS treatment was no different between infants that were formula fed and those who were provided with expressed mother's milk, possibly indicating that the act of breastfeeding is more important than the drug content of the breast milk for affecting outcomes in infants with NAS. And I can, if you would like the references to those 4 articles, you can email us at medical@handicraft.com and just ask for the references for the breastfeeding question, the first breastfeeding question after the NAS webinar, if that's helpful to you.
I have a second question here. It says, I currently have a patient who comes with vestibular movement. RNs are constantly using the swing on a high setting. What are the pros and cons of constant vestibular input?
Well, as I said in my talk, there is not a lot of evidence, and when I say that I mean research, to support the use of vestibular input in isolation. But it is an excellent question, and so there are, if I may share this with you, there are many units and therapy departments who have worked with NICU clinical staff to develop unit-specific management protocols for infants with NAS. And you know, part of their non-pharmacological management of neonatal abstinence, there's a program developed by Diane Allen at Tampa General Hospital in the Department of Peds Rehab Services, along with a doctor at University of Florida. In an effort to reduce the length of stay in infants with NAS, they did a thorough approach and developed a standardized interdisciplinary approach to improve the consistency of caregiving and reduce length of stay. And part of that was, you know, in encouraging, you know, a specific type of vestibular input, as we referred to in this talk. And so vestibular input is recommended as an intervention for infants with NAS to facilitate regulation and assist with the infant's ability to calm. So from a calm state, infants are likely to transition to sleep, which supports their growth and development, as I said. And the type of vestibular input can be offered in a multitude of modalities, such as caregivers providing gentle rocking of the infant while swaddled, placing the infant in a seat that moves at a low frequency and specific slow-grade movement, such as the Mamaroo. I know some units are using those. Not endorsing the Mamaroo, but I'm just saying that there are, you know, on an individualized basis, this could be a consideration. In fact, the Child Life team at ProMedica Toledo Children's Hospital, they researched the use of various soothing methods used throughout the nation for infants with NAS, and the Mamaroo, which is that spaceship-like swing, provides the appropriate amount of balance and motion stimulation to babies. It sways, and it has 5 different unique motions. So I think it's car ride, ocean wave, rockabye, and tree swing. in kangaroo, and then the seat reclines to any position along its axis. So it reclines for sleeping and napping, upright for interaction. It's versatile and offers a range of experiences for the baby versus a rigid bouncer seat with lights and vibration, which is not the type of vestibular input we want to provide. It's too rigid and much too stimulating. Infants with NAS most often tolerate vertical rocking patterns rather than horizontal rocking patterns, which infants without NAS most often prefer. So when providing any type of intervention, it's important to evaluate the individual infant's tolerance to that intervention, and in the case of vestibular input, the type of vestibular input, the frequency at which it's offered, and the duration need to be closely monitored at all times. So that's what I would say about that.
We have a third question here. When should an NAS scale be used? We wait for 30 minutes after feeding. Is there a guideline when a score should be taken?
The modified or modified Finnegan neonatal abstinence score system should be used when known or suspected substance exposure has occurred. So at the first signs of any NAS type symptoms, usually within the first 24 to 72 hours of birth, the Finnegan or the modified Finnegan, and I'm just using that because that's the most often used in the United States, is administered by medical staff, most often labor delivery, newborn or NICU nurses that are taking care of the infant. The assessment tool assesses 21 of the most common signs of NAS and scores the pathological significance and severity of the adverse symptoms, which can dictate the initiation of the pharmacological treatment. So staff training is needed to be consistent with scoring, which I talked about throughout my talk. It's fairly easy and reliable if staff have been trained, and there have been reports of increased subjectivity and bias that affect the scoring, and that can therefore affect the type of intervention that's provided, so that can be really difficult when you're in a situation like that. The scale can also be used to assess the resolution of signs and symptoms after treatment is initiated. So to obtain a daily average score, measurements are performed every 4 hours until the patient is stable, with 3 consecutive scores or equal. When 3 consecutive scores are equal or greater than 8, pharmacological treatment can be initiated. As I said, therapists don't typically score the Finnegan, so if you're a therapist and you might want to consider the NNS, the NICU Network Neurobehavioral Scale, to assess symptoms of withdrawal and communicate the results with the infant's care team, and that might help them to consider different treatment decisions. But in terms of when it's administered and waiting 30 minutes after feeding, I would often that is indicated, and so I would discuss that with your clinical team. And again, that's why setting up unit-specific intervention strategies and protocols is really important to understand why you're scoring, what time you're scoring, and who's taking the scoring, because that's really going to impact how you provide your interventions, both pharmacologically and non-pharmacologically.
A fourth question here, Mary, is any different feeding recommendations for children with a cleft lip or palate and NAS?
Yeah, so an infant with NAS with multiple comorbidities like cleft palate, either in isolation or as part of a syndrome or sequence, is going to require a different approach to feeding intervention than we talked about slightly. Most specifically, given the symptoms that the NAS, given the symptoms of NAS that the infant is experiencing, of course, you're going to try to facilitate state motor regulation prior to the feeding, as we discussed in the presentation, but the feeding modality will differ from a preterm or term infant with NAS, however. So an infant identified with cleft palate will, is going to have difficulty attempting to express fluid due to that lack of palatal shelving, depending on how much it is, so whether it's unilateral or bilateral. And so the recommendation would be to use, rather than a standard bottle system, I would suggest the Dr. Brown specialty feeding system to facilitate effective and successful oral feeding, because the Dr. Brown specialty feeding system has a one-way unidirectional valve that's inserted into the backside of any of the 6 standard nipple levels that are available, and so you can really change the flow rate depending on the infant's needs. And that unidirectional valve, which is referred to as the infant paced feeding valve, assists the infant in expressing the bolus, because once the valve is in place, it creates the nipple is then a compression nipple, essentially. So as the baby's tongue comes up on the underside of the nipple pushes up on the underside. I'm sorry, the tongue pushes up on the underside of the nipple, and then the fluid's expressed into the mouth, and then the infant can move the bolus in a more typical functional pattern toward the back of the oral pharynx and initiate a swallow. And so what that will help the infant to do is regulate and decrease the risk of aspiration, because it is an infant-driven feeding system versus a manually expressed feeding system, which often, not often, but historically has been used in the management of cleft palate feeding challenges.
Okay, one more question here, Mary. How long does the high-pitched cry persist as a symptom of NAS, and does the cry change or become more typical?
So that's an excellent question. So to my knowledge, there have been no studies that specifically looked at the duration of the high-pitched cry that's present. And again, high-pitched cry is a symptom of the baby not having the substance that they were exposed to. So theoretically, if you were to assess cry, again, if you're using the modified or the Finnegan and you're assessing cry behavior and you start to see changes over time, maybe the baby's cry was high-pitched prior to the intervention being provided, so before non-pharmacological or supportive interventions were provided, and then you see changes in the baby's cry pitch and variation in pitch, tone and resonance and things like this, and so that would be indicative that the intervention was working. However, no one has really looked at the duration or the length of time that you would expect to see this cry. So there are a few studies that look at the sound characteristics of cry in infants with NAS. There's a study by Quick in 2008 that state that the infant cry characteristics reflect the neurological and medical status of the infant. So we know that if the infant is continuing to demonstrate signs of NAS, that management is further warranted. So it is a symptom of withdrawal, and if we're starting to see that cry normalize, and it then would therefore seem that it's effective. But in most of the studies that I know regarding cry, they look at more the acoustical effects. There's some articles that discuss the impact of cocaine exposure on infants' cry, but again, it's not the type of cry or withdrawal symptoms we're really most often seeing in our units these days, and that article is from 1992, Corwin and colleagues. But I think that the most important thing to do there is really look at the Quick article, 2008. Again, if anybody wants the references to this, will be in my reference page, or if you want to contact us directly, I can give you the article. But Quick and authors in 2008, they looked at both the human and animal models and suggested that the cry is activated by the hypothalamic limbic system and controlled by the midbrain and brainstem regions. And the effects that they found on cry characteristics may be due to the action of the substance on the mesolimbic systems, including the blocking of norepinephrine or dopamine reuptake that affect neural development. So it's interesting. That's interesting to me because that area of the brain is also very close to the sensory system, and that's the symptoms that these babies are demonstrating. So I think it's really helpful to look at how the infant's cry changes during the course of admission and through the interventions provided.
Well, that is all the questions that we have. I would like to make note that the reference list for this webinar is very extensive and will be posted as a PDF on Dr. Brown's medical website at www.drbrownsbaby.com/medical/webinars, along with the recorded webinar. The slides are not available for distribution, but can be viewed when watching the recorded webinar. The slides are not to be reproduced without permission. Mary is happy to share her reference list. Again, it will be on the medical website. Please feel free to contact her at mss2041@tc.columbia.edu. Thank you for your time.